Good morning, everyone. We're going to move over to another subject now, a little bit away from the HIV that we have heard about earlier today. So, you were walking around with a microphone. Could I have the same microphone so that I can?
Yeah. That's one.
I think it's easier this way that I walk around. So, why should we talk about sexually transmitted diseases? Well, for one reason, we've heard about HIV earlier today. HIV is increased in patients with other STIs. It is a threat to the reproductive health of women especially. And there is an increased risk and threatening of the antibiotic resistance. And we heard Professor Kaplinski talk about that a little bit, and I will talk more about it. And we run out of effective antibiotics, and that is really a threat. I will see if I can manage all this. So, we heard about the number of HIVs. We heard about 2 million a year. I will beat that by telling you that we have 1 million STIs, sexually transmitted diseases, every day. On a daily basis we have that. Now that is big figures. We have 357 million sexually transmitted diseases only of chlamydia, gonorrhea, syphilis, and trichomonas. Only these four are 357 million every year. So that's big figures. On a given moment, we have 500 million additional persons with herpes simplex virus. We have an additional of 290 million women with human papilloma virus. We're talking big numbers. We're talking many, many sick people. And we have to fight that in an effective way. There are about 30 different bacteria, viruses, or parasites that do transmit different sexually transmitted diseases. This is a slide showing you the ages that many of these patients have. You can see here in the bottom bar, there is about equally many young people between 15 and 24 years as there are older people. However, when we get into looking at two of these diseases that we will talk more about, gonorrhea and chlamydia, there is an abundance of younger people. There are more younger people than older ones that attract these diseases. While, on the other hand, if we talk about syphilis and trichomonas, there are mainly, it's wrong to say older, but they are older than 24 years. So you have to keep in mind that there is a difference in age between these diseases. This is only to show you relatively the amount of total number of sexually transmitted diseases in the US, and you can see the big bars. The two first are virus diseases, and then trichomonas, chlamydia, HIV is here, and it goes down. So, there are in the US 20 million new cases every year. There is a total in the US of 110 million sexually transmitted diseases, to an incredible amount of money. We were talking about politicians listening and telling us that they didn't have the budget for it, but look what it costs. $60 billion US a day, and I would be happy if I could say, as Dr. Hollander said, that there is a return of 17 times as much money. I don't think it is, but it's an immense amount of money that we spend on this. So, we're going to talk about these diseases, all of them associated in a pronounced way to HIV. So, let us first say, when are we supposed to think of sexually transmitted diseases? Well, the symptoms are often very vague or even not existing. That means that every time you have a patient in front of you, you have to think, could it be a sexually transmitted disease? Don't wait for the pronounced symptoms, because then there will be lots of patients passing by. To give us some guidelines, we normally say age below 30 years. That doesn't go for vulnerable groups of patients, of course. Some groups have higher ages, but normally under 30 years. If they use unprotected sex, if they've had previous STIs, that's one kind of thinking that you need to have. Then, of course, if a young person, especially if it's a young man, comes to you with dysuria, young boys don't have dysuria. So if they have sexually transmitted diseases, if they have discharge due or changed, or if they have hemorrhage. So if we go for the discharge, men commonly have discharge, not always, but commonly. And that goes especially for gonorrhea, chlamydia, and mycoplasma genitalium. In contrast, and this is important to remember, in contrast, women do not always have a discharge related to sexually transmitted diseases. Rather, and that's also interesting, rather bacterial vaginosis or candidiasis are diseases associated to discharge. Then it's the mother-to-child transmission. That is something that leads to stillbirth, to neonatal death, to low birth weight, and we all know what that means for the child. Prematurity, neonatal infections like septicemia, pneumonia, and conjunctivitis. I have illustrated this with a painting from the Norwegian painter Edvard Munch, who is with a mother mourning her dead little newborn baby. But these are the consequences that we need to take into consideration. So let's start with the different diseases. This is a poster used in the US, Don't Be Tricked. And I think it's a very nice and interesting poster. It also says trichomoniasis increases your risk of HIV. Get tested. When we come to men and trichomonas diseases, men are mostly asymptomatic. They don't have any symptoms at all. Women, on the other hand, have itching, they have discharge, and in this case it's gray or yellow-green in color. It's an increased viscosity, and it's a very bad smell. And as we talked about earlier, the infected persons are often older, meaning around 30 years or even older than that, which in this case is called older. There are risk factors, and you will see the same risk factors for all the sexually transmitted diseases. If you have multiple sex partners, if you've had a previous sexually transmitted infection, if you use unprotected sex with no condoms, and also in this case it's been stated that if you belong to a lower socioeconomic status, you have an increased risk. So how can we do to diagnose the disease? Well, when it comes to men, and I said that men normally don't have any symptoms. When it comes to men, there is no good testing for men. It's difficult to recognize the disease in the laboratory. So we have to rely on women instead. But when it comes to women, we have the wet smear, and that is done in the clinic among the outpatients, and it does look like this. Here you have a wet smear, you have a trichomonas, as indicated on the slide. But remember, when you have a wet smear, the trichomonas have to be motile. They are equipped with these small flagellas, they move around, and they have to do it also in the wet smear for you to be able to say that it is a trichomonas infection. And then of course we have the nucleic acid amplification test, like PCRs, and I would call them PCRs in the continuation. Different PCRs that are upcoming. So we treat them with metronidazole, and the most important thing is what is encircled here. I think the partner treatment is very important that you remember. And the reason for that is, of course, that if male don't have any symptoms, you need to treat the male if you have a female with trichomonas. So remember to do that. 80% are cured, but there is resistance existing also against trichomonas. So let's move on to the next disease, which is chlamydia. And I found this poster, which I thought was quite illustrative for the disease. Here we also have the very vague symptoms or no symptoms at all. And that goes particularly this time for women who don't have symptoms. They are mostly found when they go to the clinic to get the contraceptives, and this is where you find them. But they don't complain of any symptoms. Men have urethritis, women can have urethritis, and they can have complications in terms of psoriasis or salpingitis. There are two kinds of chlamydia diseases. When we think of chlamydia, we normally think of it as the common one, the one that is not so dangerous to the patient. And that is the chlamydia caused by the genotypes D2K. It's the one that is non-invasive and the one that has epithelial cells as targets. However, there is another one. The other one is very rare, but it is also very dangerous. It's the one that is called lymphogranuloma venereal. It's caused by the genotypes L1, L2, and L3. And that one is invasive. And contrary to the common chlamydia, it targets the lymphocytes and the macrophages, and it causes much more harm to the patient. All chlamydia are intracellular bacteria. They are found in the secretion of the patient. They attach to the epithelial cells and they invade. There, these elementary bodies transform into reticular bodies, and they multiply, reorganize, and then back to the elementary bodies, which then in the end are released from the epithelial cells. And these elementary bodies are infectious. And if anything, you want to stop this step to happen. So I mean, if you could have a condom somewhere, you should put the condom here to prevent these infectious particles to be released from the epithelial cells. So how do you diagnose chlamydia? Well, you nowadays have a very simple method, namely taking a urine sample. And you should also take a vaginal sample. This vaginal sample can be taken by the patient, by the woman herself. It's shown in several studies that even the self-taking vaginal sample is better than when doctors or midwives or nurses help by taking that. So it's not bad with a self-taken vaginal sample. That improves the chances to have a positive result from the testing. Again, you test with PCR. Formerly, you used to have culture-based techniques. These are, however, the PCRs are higher sensitivity, higher specificity, and more rapid. So these are much better as compared to the culture that we used to have previously. Then I need to point out that there are point-of-care tests. And in my country and in many other countries, there are several of these. They are generally not good. So if you're using it, be sure to check out with your local laboratory how good or how poor it is, because many of these are not good at all. So be careful with them. Well, the PCR changed a lot for us. The diagnosis was easier. You could use urine samples, which was easier for the patient. And you can see here the trend over years. You can see how it increased. We were extremely happy in Sweden, because this is from Sweden. We were extremely happy that we had a plateau there. And we sort of bragged about and said that we were so good, we had stopped it when we have heard previously about stopping diseases. However, what turned out was that there was a mutation in the chlamydia bacteria, so that it was not caught in the test that we had. So the increase that you see here, that's a catch-up effect. And now we have changed the testing and improved it, and now we have 2 target genes. So what we recommend in therapy is oral doxycycline and azithromycin. Difficult to say in English. Anyway, we have treatment failures with azithromycin, and you should be aware of that, and we should keep that in mind as we walk along. Then we should talk a few words about this rare, still very dangerous disease, the lymphogranuloma venereum. It's most common in Asia, Africa, and Latin America. And when we come to Europe, it's mainly in men who have sex with men or have other high-risk behavior. There are 3 stages of the disease. The primary, where you have ulcers, which still is a self-limiting stage. The secondary, where you have a painful regional adenitis, and the third stage, where you have the genito-anorectal stage with a chronic inflammation. There is a high comorbidity with other diseases in lymphogranuloma venereum. Here you have 80% of these patients with lymphogranuloma venereum also have HIV. That means you have a patient with lymphogranuloma venereum, you have to test the patient also for HIV. There is also a comorbidity with other sexually transmitted diseases that you need to keep in mind, primarily with syphilis and with hepatitis C. You diagnose it with a urine sample with PCR. You can also take from other localities. And then if you have the suspicion of lymphogranuloma venereum, don't forget to send it for specific diagnosis of that disease. Treat it with high doses of doxycycline for a longer period of time. Now, we learned today that HIV was first discovered in 1981. Mycoplasma genitalium was discovered at the same time. It's a slow-growing intracellular bacteria. Bacteria is difficult to culture. It looks the way that you have it here on this slide. Pear-shaped with a little adherent tip, and the tip makes it easier for the bacteria to enter into the cells. Interestingly here, the bacterial load is much less than for chlamydia. It's 1/100th of the number of bacteria that you find with chlamydia. That puts great demands on the laboratory methods, otherwise we'll never find it. The symptoms are fairly similar to what we have seen before. Remember that it's not clinically possible to differentiate between chlamydia and Mycoplasma genitalium. There is a strong epidemiological association with HIV. It's suggested to be a cofactor for HIV, and it predisposes for HIV. When you look at the prevalence, how common it is, you can see that it differs a lot in different populations, but normally we say that it is as common as chlamydia. That means that it is very common. It's a disease that you need to think of if you have a patient with a risk behavior. It is also important to remember that it lacks the cell wall, meaning you cannot treat it with penicillin. So, what do? There is a risk of false negative results because of the low bacterial load. What kind of samples do you take? You take urine together with vaginal samples. Vaginal is better than urine. The patient is the best taker of the sample. And remember, you should have a volume that is big enough because of the low bacterial load. So, what are the treatments? We talked about guidelines previously. There are no guidelines for Mycoplasma genitalium. However, you normally treat it with azithromycin or doxycycline, but, and this is the important thing, and that is why I stressed the azithromycin with the chlamydia, there is increasing resistance towards azithromycin. You need here higher or prolonged treatment, and moxifloxacin is an alternative, although not a good alternative. So let's go to this disease, gonorrhea. Difficult to spell, easy to catch, it says here, which is very true. There is a 4-time increased risk of HIV if you have gonorrhea. In Sweden, and I think in many other countries, there was a peak in the 1970s. Many call it the rock and roll area. Sex, drugs and rock and roll was popular at that time, and that of course led to very high numbers of gonorrhea. Then it decreased, and we're in Sweden down to 1,000 cases a year. But as Professor Kaplinska pointed out, the big threat is the antibiotic resistance, and we keep that in mind. Men and women, you have seen these symptoms before, they are the same. So what can we do? How can we have the diagnosis? The diagnosis is easy with the PCR methods, but you also need a bacteriological culture. And the reason why you need a bacteriological culture is because of the high resistance towards the antibiotic that you still have left. So this is the superbug that we heard about. It doesn't look very much super buggy to me, but it still is. You can see it here, the small dots. And in low resource countries, the gram staining is the only thing that is left, or the only way of making the diagnosis, because they don't have the money neither for PCR techniques or for bacteriological cultures. This is an intercellular microorganism, as you have seen it. You need to be able to treat it. You need to see the intercellular diplococci. You need to have a positive culture or a confirmed PCR. However, in countries where you don't have all these possibilities, the epidemiology, if a partner has gonorrhea, is enough. And also in the poorer countries, clinical symptoms of gonorrhea is also enough to start treating. This is a bacteria with an extraordinary ability of changing genetically, and that is of course the reason why we have all these resistant strains. We still can treat some of them with monotherapy, but it's getting more and more difficult. Normally we treat with combination therapy or with neuro drugs. So let's go into the last disease. This is syphilis. This is a poster from 1936. Already at that time it was a disease of great importance. And what you can see also on this poster is how they bend down their heads and they feel a little bit ashamed of the disease. And this is the disease that is mostly associated with shame, and the disease that people talk the less about. Globally, is a common disease. We have 12 million new cases every year. It is a disease that is transmitted with sexual contacts, blood or blood products, and a mother-to-child transmission as well. We have congenital infections, and therefore we advocate and we try to make the hospitals screen pregnant women for syphilis. The disease can be divided into two parts. It's the early stage of the disease and it's the later stage of the disease. The early stage is normally what happens within the first 1 or 2 years, and the later stages is what happens afterwards. And what you see here is the spirochete in an electron microscopy slide. It has this very particular way of looking. So the symptoms are, in the primary stage of the primary syphilis, you have the non-hurting wounds and the non-hurting swollen lymphoglandular. In the secondary stage, you have skin lesions of different kinds. And in the third stage, you have the symptoms and the diseases that normally is found in the literature. When you read books about syphilis, it's about the neurosyphilis, about the skin lesions, the pronounced skin lesions. When I started studying medicine, the cardiovascular diseases caused by syphilis was one of the dominating diseases that the patients were admitted for. And also remember, there is an increased risk of HIV patients to have early neurosyphilis. So how do you get the diagnosis? Well, this spirochete, this bacteria, is not able to culture. We cannot culture it in the lab. So we only have the indirect methods, meaning that we have coming from the wounds, we have the PCR methods and the microscopy. However, what is mostly used and is used from in most of the laboratories, that's the serology. And there you have two different kinds of serology. You have the specific and the unspecific serological tests. And you can never base your judgment if a patient has syphilis only on the unspecific tests. So be sure to base it on the specific tests. And if you have a patient with HIV, the results from the serology can be disturbed, meaning that it can either be false positive or false negative. So remember, if you're HIV patients, there you have to be careful with interpreting the results. So how do you treat? Well, you can treat with penicillin, and here we have no resistance reported so far. Some people want to treat with other drugs, they can do that, but remember, when it comes to azithromycin, there is a resistance reported against that drug. When it comes to HIV, there is a 3 times increased risk of HIV, mainly among men who have sex with men. I've already pointed out the risk of misinterpreting the laboratory testing, although it is normally okay, but remember to be careful. increase the risk of neurosyphilis, as we said. And if you have a patient with HIV and syphilis, you need to retreat the patients after 1 week. So there is an association, if we are to summarize, there is an association between HIV and STIs. There is, remember the risk behavior. There is an increased risk because there is an inflammation of the mucosa and the ulcers, particularly in the syphilis patients. So these are the reasons that we have for an increased risk for HIV and sexually transmitted diseases of other kinds. So how can we prevent sexually transmitted diseases? Well, first of all, by having a generous view of testing for sexually transmitted diseases. I said that from the beginning. Remember, not all of your patients will have any symptoms at all. We have to be generous screening certain groups that we believe are at risk. You have to be generous with contact tracing, partner notification, and treatment. And we heard from Dr. Hollanders earlier about the campaign week for HIV. You can do the same for other sexually transmitted diseases, having campaign days, having open clinic days, and having easily accessible testing sites. So the take-home message, where I will end, the take-home message is that many of the sexually transmitted diseases are asymptomatic. And please remember that. They don't have these fulminant symptoms. That goes especially for women, but men hardly ever have any symptoms if they have a trichomoniasis. Be generous and test for sexually transmitted diseases. Co-infections are common. If we want to prevent the spread of infections, we have to start treatment early. Resistant strains are common. They are far too common. We are running out of antibiotics, and if anything is a threat to us, this is really, really a huge threat to us. So remember, be careful with the drugs you use, but use them quickly. And by that, I would like to thank you very much